the OrthoPAC, hosted by Sam Dyer. Welcome to the OrthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Listeners, today's podcast, you got Chuck Dowell, Miles Gilbreath, and myself discussing what happens if you make a mistake. What our thoughts are on when things happen, when things go the way you don't want them to go. Chuck, please lead us off.
Yeah, thanks, Sam. Yeah, so I had a colleague reach out to me, a younger PA in her first 5 years of practice, and she did a intra-articular injection in the office, and the patient had some pain afterwards, which, we've all experienced pain after injection. Some people have inflammatory reaction. She treated that appropriately with anti-inflammatories, and the patient continued to have pain afterwards. And there was a concern about possible infection. They ended up getting an MRI, which showed an increased uptake within the femoral head. And there was a concern about a possible, sepsis within the hip. She reached out to me, a little bit distraught and a little bit concerned because this is the first time she's had a complication, with patient care, and she wasn't quite sure how to handle it. And so I thought it would be a good topic for us to discuss. I think as you get more experience in healthcare, complications happen. It's unfortunately part of the job. But understanding how to handle those complications and the emotions to go through, I think, is an important aspect of it, and something that maybe we could discuss and, like you said, Sam, have a roundtable on, and maybe provide some pearls of wisdom to, younger PAs who are establishing their career and may run into some of these complications, and they can kind of know how to navigate through it, if that makes sense.
Yeah, absolutely. I think it's a great idea. And this is our first open mic without a script, so I'm excited about it. I have actually some experience with post-injection issues, but I don't have an intra-articular story to tell. I haven't seen one, knock on wood, where somebody's had an infection, but, stuff happens. And I guess I'll share my story. When I was early in practice, definitely in my first year, probably in my first 6 months, I had a very attractive young female nurse come in with pes anserine bursitis. And I hadn't seen that, so I asked my supervising doc at the time, who was mentoring me right along, how to manage this. And he said, well, you can try an injection. And so I said, okay. So I gave her a full 4-in-1, 4 of Margaine and 1 of Kinlog, right into that, minimal fat skin area of the pes anserine. Everything was great. She left. About a week later, comes in with this huge white spot and just flipping out that I had just cosmetically damaged her. And at that point, I kind of had the same feelings like, oh my God, what am I going to do about this? I don't know. So I asked him, and, we all know that this skin depigmentation, fat atrophy and stuff will get better, but it takes a long time. But when you're shaking in your boots and you got to go tell her, don't worry, this is going to be okay. I mean, it's pretty trying. It's pretty traumatic. And, I've had a few instances of similar kinds of things. And those things stick with you. I mean, you learn from that. And that's one of the key takeaways, I think, is that this whole thing is a practice. It's not it's not 100%. And sometimes a mistake is a mistake. Does a mistake mean you committed malpractice? No, it does not. Those are two different things. There was no willful intent. You did everything right. And sometimes stuff happens, and it's just the way it is. Now, I learned from my mistake that, you got to monitor those volumes and the amount of dose that you're putting into an extra-articular structure. And I've carried that with me. I've never forgotten it. And I've also learned that, Celestone is a water-soluble instead of fat-soluble medication. So all of those things kind of go in. So you kind of learn as you go. And actually mistakes, they happen. And sometimes you learn from that. And sometimes you do something and you do 100% like everybody else would do, and bad things happen. And it's not a mistake. It's just one of those things where stuff happens sometimes, and it's just part of the job. And that's kind of what I think about that. And I don't know what you guys think, but I'll let you, this is Share the Mic. So let's see what you guys have to say about that.
Yeah, Sam, I completely agree with you. And back to what Chuck said, I have a physiatry colleague that I talk to on a regular basis, and him and I both knock on wood every time we say it. We still haven't seeded that intra-articular injection yet. And we kind of joke that if we do this long enough, at some point, we'll see a knee infection after an aspiration or an injection. And, we're just waiting for the day that we have to manage it. I've definitely seen my fair share of fat dimpling and skin discoloration post-injection. And I definitely, think that's where we go back to that informed consent aspect of the procedure, right? Make sure they know that that's a side effect. Make sure that they know that it will go away. It's not going to last forever. I definitely agree with you on that, on the practice. And, for people with darker skin color, I usually offer the option of Celestone, like you said, and just trying to mitigate those risks and making sure the patients are informed of them on the front end goes a really long way.
Yeah, I think, like you both have said, we go through the risks, with these injections and procedures with patients, knowing that these are documented risks. And as Sam and Miles both said, not all of us will see these complications in our career, but, if you're doing enough of them, the documented risks are that you potentially will see one in your career. Lucky enough, this patient's labs came back negative and it didn't turn out to be an infection. It turned out to be avascular necrosis, which can also be a complication from an intra-articular injection. But as Sam said, how do I deal with this? How do I deal with these emotions? Her initial reaction is the initial reaction I think all of us would have. Hey, I never want to do an injection again. I think I may quit being a PA because now I've caused harm to somebody. I don't want to practice independently. And she went through all those emotions that I think we've all been through with complications or, side effects in our career. And so my advice to her was similar to what Sam said. I recommended that you give yourself a day, go through those emotions. I think you should let yourself feel those emotions because those emotions are important. Process that however you can naturally process that, and then learn from it. And that's, we've all learned from our mistakes. We've all learned from missed fractures or misdiagnosis, complications to procedures, and just make sure it never happens again. If there's a correctable factor that you can correct, hey, maybe, the way I do that procedure, I skipped a step. The next time I won't skip that step. Then correct that factor and you'll never make that mistake again. So that's kind of my advice, similar to what Sam said, was what can we learn from this? What can we take away from this? Is there something that is under our control as a provider that we can correct? And if that is a correctable thing, let's implement that into our practice to correct, and let's never make this mistake again. I've talked to her a few days later and she processed those emotions and went through the natural process and then was able to learn from it and understand, how and or why potentially this happened. And hopefully then we'll correct it in the future. And like Sam said, I think I've been doing this long enough where these things have happened and every single one of these sticks into my brain. I can give you the story of every single one I've ever had. And I've learned from all of them and I've tried to be better due to all of those.
Yeah, I can't tell you how many times, and I guess my first 6 months, first year, that I'd write a prescription or get an x-ray and go home at night for 2 or 3 hours, looking through the book. Oh my gosh, did I just kill somebody? Oh my gosh, did I miss something? Oh my gosh. And, that's just experience. It takes time to feel like you got your legs under you, like you feel confident with everything. And things happen sometimes. You mentioned missed fractures. I thought that might be something we can talk about too. I can remember vividly a missed fracture from 15 years ago. I knew the family, saw the whole family, saw the kids growing up, and missed a scaphoid fracture. It happens. And unfortunately wound up needing surgery. But, I told the patients and everything, the legal team might disagree with this, but I told them, look, I totally missed this. I'm so sorry. And, it didn't change the outcome. Everything did great. And they told me they appreciated it, but they trusted me, implicitly. And thanks for being honest. So it's a practice, it's not a 100% same every time. It's a practice of medicine and you do the best you can. Now, I think with the injection thing, and I think Chuck alluded to this somewhat, look at your, how you go about your steps, your procedure. Are you wiping the vials? Are you using different needles? Are you, using betadine? I don't think you have to change things too much, but look at your process. And if it's a one-time thing that's happened after 500 injections, I call that a fluke. It's not a big problem, but it's helpful, I think, to review your processes, like just the simple things of drawing up the injection, checking the expiration dates, making sure you got good, several betadine wipes, whatever. And I think that might help too. Just curious, Miles and Chuck, what kind of other things have you had that have been problematic that left you thinking? And don't expose yourself to
Yeah.
malpractice, which I don't think you are. Everybody makes mistakes from time to time. It happens. Go
I've
ahead.
got a couple that kind of came to mind, and some that one that came up when you were talking about preparation of injection. A lot of the times we rely on our clinical teams to draw up our injections. I don't have as much experience as you guys have, but I do run a relatively busy after hours urgent care clinic. And so there are times that I need an injection, an aspiration or whatever drawn up while I go see someone else to then come back to that procedure. I find myself being quite the stickler when it comes to drawing up injections. And I've had my current clinical assistant for 6 to 8 months, and I'm still daily kind of reminding her when I see her drawing up injections, different things. Like yesterday, it was holding the syringe to make sure this doesn't mix into that bottle. So I find myself kind of being a little bit controlling around that aspect of the procedure to control that variable. And I think it just comes from years of experience and years prior to being a PA when I drew up all of the injections. And so I just know that they don't have the same comfort level with it that I do, I would say.
If we talk about the injection thing, one of the things I saw early on were people drawing. Now, we use multi-use vials. I don't know what you guys use, but we use multi-use vials for our local and our cortisone, both Celestone and Kenalog, which are, basically the only two we use. And people using like 18 gauge needles to draw those up because it comes out faster. That was the excuse I got. What happens when you lacerate that rubber stopper that makes it a multi-use vial with that big needle is you can get little floaters of that material in there. I've seen it. And
Same.
so I had Joanne, my medical assistant, keep, all our supplies separate from everybody else. If somebody else does that, I can't help it. But for us, no larger than a 22 to draw up the fluids and that sort of thing. So things you can do on your own, don't assume that everybody else is, and it doesn't mean everybody else is wrong, but just, what's right. Your pathways, your algorithms. Stick to your guns and, do it your way, do it the right way.
I completely agree with you about drawing up with a 22. I remember learning that from one of my more senior partners when she wouldn't let me draw up with a 22 when I had for a long time. And, seemingly everyone else around me drew up with an 18. And then I saw that little floater, I saw that little piece of silicone. And I did not want to inject it into the patient's knee. And I've never drawn up meds with an 18 gauge since. And that was probably 4 years ago. That's not necessarily standard practice, unfortunately, it seems. But I agree with you on that. This is a practice, like you've said multiple times.
Stay tuned next week for the next part of our discussion about mistakes and what happens when they happen. Listeners, we're halfway through the last quarter of 2024, and I hope you have taken advantage of our free CME offer for members and our new membership drive. If you haven't, please look at PsO&x.org for details on how you can get some free CME before the end of the year.